I know where you guys are at, right? Like, I was an intermediate, I wasn't a paramedic, but I do understand where you guys come from, right? I worked on the adult side of the emergency room as a tech, and there was a charge nurse on the ped side that would always be like, when are you gonna come over here? And I'm like, I don't do kids. And she's like, you will. And I'm like, no, don't do kids, right? Nobody wants to deliver a baby. Nobody wants to take a peds call. And then one day I got mad at one of the nurses on the adult side. And I was like, I don't go to peds. And I was there until I transferred to SRNC. So last year I was asked to do a presentation at the Red River EMS conference. So this was the one that I did for this. And it was just kind of tips and tricks that I had collected over my years for things that I saw that were commonly missed or maybe not the appropriate treatment from EMS, right? So this was my presentation. So first I wanted to know why is peds care so lacking? So when I started looking at it, 7% of your calls are pediatric calls. Of that 7%, 85% of that 7% need nothing more than a Band-Aid. How are you ever supposed to get good at treating kids when you see them so rarely? The key is to focus on what's most common, right? You can't learn everything. But you can learn the most common presentations that kids are going to bring to you. So this is kind of what this is talking about. So these are the most common issues with pediatric patients, right? Respiratory is huge for kids. Respiratory arrest is the leading cause for cardiac arrest in kids. If you don't catch the respiratory fast enough, they're going to go into cardiac arrest. One of the biggest things that it drives me insane is blow-by. Blow-by is completely ineffective, right? You have the oxygen over here and the baby's face is over here, and you're trying your best, and I'm like, why didn't you just put a cannula on him? I didn't want to make him cry. He's a baby. He's going to get over it, right? And he needs it. So do the most effective and the most appropriate treatment, right? People struggle with stridor versus wheezing. Work of breathing versus your SpO2. Makes no difference to me if we bring in a kid satting 96% who is breathing 60 times a minute. Would you bring in an adult that's 96% breathing 60 times a minute and be like, they're good? Absolutely not, right? Why is that kid good? They need oxygen. Their work of breathing. They're working so hard to get to that number. The nasal cannula versus blow-by. Retractions. Kids retract. But how do you know if a kid's retracting? Right. Like, you gotta lift their shirt and look at them. And the more higher up the retractions, the more severe the retractions are, right? Like, they can have subcostal retractions and maybe some belly breathing, and they're just working a little bit. They can have tracheal tugging and supraclavicular retractions, and you're a little bit behind the curve. So you want to be a little bit more aggressive. Kids are pretty gross. Their noses are always gross, right? They don't know how to blow their nose, so you have to clean it out for them. In a hospital, we'll basically waterboard these poor kids, right? We will wrap them up in a sheet and shove saline up one side and suck it out with the suction on the other side. If you can clear their nose, they're going to breathe better. Especially small kids are obligate nose breathers. If they can't breathe, they won't eat, they won't. So they just create this cycle and they create their own little perfect storm. Clear their nose. Getting a kid to take medicine sometimes, it's like wrestling an alligator, right? Like, they don't want to do it, but they have to. Fish hooking them when they won't take it. We'll go over that in a little bit. Starting IVs. Starting IVs is always super scary on kids. My recommendation to you guys whether or not a kid needs an IV, you're always pretty close to a hospital, right? You can start a line without a kid fighting you by yourself, they needed that IV. If they're gonna fight you, you probably have time to get them to a hospital where you have more. And no one's gonna fault you if you're like, you know what, I tried and this kid was fighting, I felt like I had time. They will fight you or fault you if they're like, I poked him 8 times and I couldn't get it. Why? Right? Like at that point, they're fighting you so much you probably had time. Giving Dex. What do you guys know about dexamethasone? Mm-hmm. So it takes 4 to 6 hours to start working regardless of how you give it. Whether it's a shot, IV, oral. So the faster you get that on, the faster they're going to start to get better. So it's super important when you're on scene and you have that creepy baby with stridor, you have that asthmatic kid and it's in your protocol, give the Dex. If you're going to give it IV, like in EMS, everything is like a fast push, right? Like adenosine is super fast, everything else is kind of a fast push. If you push Dex too fast, it makes your butt really itchy. And they'll like scoot around on the bed like a dog on the carpet, and it's because you pushed the Dex too fast. It won't hurt them, it's just uncomfortable. You're like, what is happening? Because they're like scooting around. And then special populations, right? Patients with special needs, they're always a little bit more challenging, right? Like maybe they're not verbal, maybe you don't know what their normal baseline is. So how would you find that out?
That's parents.
Your parents, right? Generally, parents of chronic kids are one of 2 ways. Like they are either super involved and can tell you everything about their child, or they're like, I don't know, somebody said they have like a hole in their heart, but I don't know what it is. I was supposed to take them to the doctor. Difficult parents. You don't have one patient, you have like 2 patients or 3 patients, and they're like standing over you, and you're like, back up, right? I always try to like make sure they're involved in the care, give them a little bit of control to the situation, but also stand your ground. They called you. You're there to help their child. Aggressive patients, and we're gonna talk more about this in another slide. It's hard to think of kids as aggressive, but they are. And that's when we get hurt, right? Like we let our guard down because they're little. They have no impulse control. They fight for their life. So you have to always kind of just make sure you're a little bit more aware. And then making sure you guys take care of your mental health needs, right? Like your job is hard enough to begin with. You add on to that the impact of a significant pediatric call. I mean, spend time circling and beating yourself up and could I have done something different? To make sure that you have a good support system already in place, in that you have someone that you know you can talk to. Sorry, it's a little blurry. So this is a pediatric assessment triangle. This is my scene safe. What do I see as I'm pulling up? This is that for a peds patient. You have the majority of your assessment done before that parent brings that child to you, or you make your way to that patient. Their appearance, do they have abnormal tone? Are they interactive? Are they difficult to console? Why would difficult to console be something that you'd be concerned about?
Could be in pain.
Pain? Or something's going on in their head. When babies are hard to console, it can be from like infection, it can be from trauma. They'll have like a weird cry, sounds like a cat. Those are things that you want to kind of pay attention to. And it can be hard, right? Because babies cry. But are they difficult to console? Like a normal baby, you could usually pick up, kind of pat them, and they should settle. Is this baby not settling? Do they have an abnormal look or gaze? They brought a patient to us one time who had had a seizure on scene. They knew this kid had seizures. They brought him in and they were like, he's been so good. He's just been looking at me the whole time. I thought, he's seizing. Like, the kid was literally like this. But the kid was quiet, right? So they were like, this is perfect. Like, he hasn't cried. He's not making a fuss. He's just been looking at me. He was still seizing. And then the abnormal speech or cry. That high-pitched cat noise. Their circulation, their pallor, modeling, cyanosis. I'm pretty fair-skinned. I'm always modeled. When babies look like this, I usually ask parents, especially if they're lighter, does their skin always look like that? Does it always look lacy? If they say yes, I'm not quite as concerned. But if not, then they have something going on with their circulation. A lot of times, though, it's fever. They're really febrile, and they're kind of mottled. And then their work of breathing. Are there abnormal sounds? Are they sitting in an abnormal position? Are they retracting? Do they have nasal flaring? Any apnea or gasping? Do you guys have any questions about that? Like, if you can learn that and own that, the majority of your assessment is done. You know what normal is. Here's your abnormal. If something hits one of those, like, honestly, the way that we would gauge how sick a kid is, if they have one, they're sick. If they have two, they're sicker. If they have three, they're the sickest, and you want to move quickly. The majority of cardiac arrest is respiratory related. We just kind of touched on that, right? There's a lot of reasons kids go into respiratory arrest, right? It could be because they're sick, it could be because they're chronic, it could be because they're really naughty and put everything in their mouth. So those are just always kind of the things that you want to think about. And we'll talk a little bit more about those in the respiratory curves. Respiratory season's coming for us, right? Kids get sick. Some kids get sick very quickly. Knowing normal things about respiratory illnesses for kids is kind of important. Most viral respiratory illnesses in kids, days 3 through 5 are going to be their worst. So if you go on scene and this kid kind of looks cruddy, they're kind of working to breathe, and you're like, Mama, how long has the baby been sick? 1 day. What would you expect to happen with that kid? They're going to get worse, right? So that's the parent that you want to encourage the transport, that you want to be a little bit more aggressive in your care. But if you go on the same call and they look kind of cruddy, they're on day 5 or 6, probably they're over that hill, right? You still would want to encourage them to get looked at, but maybe they're not quite as bad. Maybe they should have called a couple of days ago if they still look crummy like that, right? We talked about nasal hygiene, cleaning out their nose, lobi, and the number on your stat versus the patient's numbers. And this isn't just EMS, right? Like yesterday I went to work. There was a 4-year-old. He was an asthmatic. He had gotten nebs, and he was on oxygen. And his heart rate was like 146, and he was satting fine, but his heart rate was high. And so I asked the nurse who was taking care of him, like, hey, when's the last time you had albuterol, right? Albuterol can make you tachycardic at noon. And I was like, you probably need to go up on his oxygen. And he's like, he's satting fine. He's like, he's tachycardic, right? And when I went and looked at him, he was tachycardic and tachypnic. And he was like, I mean, he's been doing fine all day. And I was like, cool. And I turned up his oxygen. And when we transferred him, his heart rate was 106. He just needed more oxygen, right? And this is a nurse who had been a nurse for a long time, who was a paramedic for a long time before he was a nurse. Kids are what I know. Like, I can tell if an adult is sick. Adults are easier to tell if they're sick than kids, right? I don't always know what to do to treat the adult, but I can tell you if they're sick. Kids are a little harder and people get a little weird about it, but I was like, this kid needs more oxygen, right? So I turned it up. So he went from 1 liter to 3 liters, and it dropped his heart rate by 30 points. 40. What are some reasons for stridor?
Inflammation of the airway.
Mm-hmm. And how would kids get stridor?
Like epiglottitis.
Exactly. If you suspected epiglottitis, do you know what would be a key question to ask the parents? It's okay. Hmm? Yeah. Is your child vaccinated? Hib is the virus that causes epiglottitis, right? So if they're not vaccinated, they're at greater risk for epiglottitis. They're usually febrile. They usually look cruddy. They're usually sitting forward. They're usually drooling. That is the child you don't want to mess with. But vaccines are key usually to that one. What does stridor sound like?
The whistle.
Yeah, right? Like it's upper, and sometimes it's confusing because they're usually congested and they kind of sound like, it kind of sounds like their nose, but it's usually just like, and it's on inspiration. Are you more concerned if a child or a person has stridor at rest or when they're agitated? At rest, right? Because they're calm. There should be no reason. Like sometimes if they're agitated, everything is just, they got more mucus, they're crying, so you can kind of explain it a little bit more. Stridor is one of those things that like we'll address immediately, right? We go into the lobby full of kids in the middle of winter, and they're crying and they're coughing, and you would hear that noise and you'd be like, whose baby's making that noise? Okay, come with me. Like, it's just a noise that you learn to listen for because it's important to get ahead of. If your protocols allow, this would be the kid that you would do a racemic epi and dex for. Oh, also kids put everything in their mouth, right? Foreign bodies cause stridor. They sit there and they make that whistling noise because they're obstructing their airway. That's usually the child that mom says, I was making dinner, they were playing with their sibling, they were on the floor, and next thing I knew, this kid was making this noise. That kid probably put something in their mouth. Learning the common, like the phrases that parents will tell you helps you kind of narrow down what it might be. Croup and stridor is usually like, oh, they were a little bit sick today. I put them down for bed. They had been sleeping. They woke up making this horrible noise. I took them outside to bring them to the hospital and it stopped. It's probably croup with stridor, right? So I'd ask, like, do they have that bark-like cough? Is their voice hoarse? A hoarse voice can be the same key as the croup-like cough. Not everyone has the cough. They'll almost always have the hoarse voice. A baby will have a hoarse cry. They just, and the parents think sometimes they've been crying so long they made their voice hoarse, but it's usually because they have a respiratory infection. Do you know what this is? A steeple sign, right? And that indicates that narrowing of that airway. That's pretty common with pretty bad croup with stridor. It can be common with epiglottitis. Like you guys wouldn't be able to see this, right? But when we do see this, we get concerned, right? Because now we're behind the curve a little bit. It's affecting their anatomy. Why doesn't albuterol fix croup?
It's not a bronchial formation.
Yeah.
Right. Croup is upper. Albuterol is for lower. So racemic epi would be your go-to. These don't always work, but we can try.
Kevin, maybe you know what racemic epi, is that something we would have to call MSEP for to make ourselves, since we don't actually carry?
We would just do, so the racemic epi and the epi that we would carry and nebulize is, they're different. It's like a left hand and a right hand.
Right.
But we have in our protocol or our formulary that
You
we
make
can
your
give.
own?
No, we can just give nebulized epi.
Okay.
So that's what we would do.
Yeah.
But
It's-
no, it doesn't constitute calling consortium or MSEP or anything like that.
Yeah, that's what most EMS services have, right? Like you kind of make your own.
As far as like an intermediate or basic bus, because it's probably better to just get patient to the hospital than wait around calling for like MedCom or
Absolutely.
ALS. What kinds of treatments then can we do since we can't give epi like that?
Can you give Dex?
I can as an intermediate.
You can. I would give them Dex, and you can do just cool mist saline, like set up what's a saline in a neb, and just kind of cool mist them. Yeah, it gets them something going. You can do that with like you would block the mouthpiece of the neb with a glove or whatever, and let it blow out the other side. Or you can put like a small mask on if they'll tolerate the mask. I wouldn't fight them too bad if it's just saline to try to get into them. Put them in a position of comfort, and then just kind of assess their breathing and watch them. But getting that Dex in is key. It tastes really bad. Have you guys ever tasted Dex?
Yes.
It's awful, right? Like it's got this really weird aftertaste. So if you're gonna give it oral, commit to it. Get it and try to get it in the back of their mouth and get it down in one. They're not going to give you a second chance or give them a shot. So my sounds aren't working. Basically, it's just a YouTube sound of what Strider sound. So the nasal hygiene again, clearing out their noses, right, is super important. We have like a special little mushroom tip thing that we can put in their nose, but honestly, like your yonker would work the same. Just put it at the end of their nose and you literally squirt saline in this side and get it out on the other side. If you're not getting it through, they're blocked in there somewhere, and you just have to be like a little more creative. Sometimes rubbing their sinuses. Sometimes you'll put it in this side and suck it out that side until you get like a bigger chunk out, and then you can flush it through. They don't love it, but it is super effective.
With the nasal suctioning, at what point do you want to err on the side of caution that when there's a kid who he's got like a real bad respiratory infection, but he also has several recurrent like ear infections on top of that?
Mm-hmm.
Is that something that you would want to kind of err on the side of caution with nasal hygiene, or just?
No, because I'd want to do my A and B first.
Okay.
The things that I look for when I'm doing nasal suctioning is the response to it, right? Sometimes you make them a little hypoxic. How fast do they recover? If they're taking a while to recover, it's probably not worth it, right? They don't have any more reserve, and so you're just gonna push them. But if they're recovering well, even if they drop a little bit, as long as they're still breathing, their stat isn't terrible, clean them out. Another thing that kids do, because they're kind of jerks, sometimes hold their breath. They are committed to this. They will hold their breath forever. And it's terrifying because you're like, oh my God, this baby is not breathing. They're just being a jerk, right? They're literally holding their breath because they don't like what you're doing. And I usually ask the parent, like, do they hold their breath when they get mad? Oh, yeah. But there are kids that are so committed to holding their breath that they will, like, pass out, and then they look like they're seizing because your body jerks a little bit, right? And the parents, like, freak out. They're just naughty. I mean, you don't want to tell them they're just naughty, but, like, in your head, you like, it's kind of naughty. Bronchiolitis, that's like the umbrella of respiratory illnesses for kids, right? Their bronchioles are a little bit smaller, so this is where they tend to kind of get all of that junk. It's the inflammation of their bronchioles. They're worse 3 to 5 days, right? They can have lung sounds that sound similar to wheezing. Prior to COVID, they did not give albuterol to kids with bronchiolitis. COVID ruined everything. COVID has changed everything. No one would fault you now if you tried albuterol on this kid. Because kids that were never responsive to albuterol before are now responsive to it. I don't know why, but like before, they'd be like, oh, I should give albuterol. And now they'd be like, what? I mean, it was worth a shot. They usually have a runny nose and a cough. That cough can last forever. It can last a couple good weeks. And oftentimes they require supportive oxygen. And they're usually less than 2 years old. Bronchiolitis caused by RSV. So RSV is kind of its own beast, right? And the difference in that is their mucus is usually really thick. It's like they have cement in their nose. Like it's really hard to clear. They can't get it clear. They're usually a little more febrile, a little more fussy. RSV can kill an infant. Infants become apneic with RSV. So it's really important if you think that that baby has a viral respiratory thing going on and you're like, this baby's breathing funny, to be like, let it get your spidey senses going, right? But it's also important to count that respiratory rate for a minute. Do you guys know why? Especially in babies.
They're breathing regularly.
Yeah, they're periodic breathers, right? So they will literally be like, so if you catch them in they're tachypnic. If you catch them in they're not breathing. So if you count it out for a minute, it usually balances out, right? Knowing your normals is important. I usually have a card. It just has normal vital signs for ages and their heart rates, their respiratory rates. And it's not wrong to refer to that, right? Like it's hard to remember all of these numbers. It's super hard to remember numbers on a population that you don't deal with all the time. So you would want to know your numbers. Giving a kid medicine can be hard. There's a couple different things you can try. You can try to persuade him, be like, come on, buddy. Like, I just need you to take this for me. You're gonna feel better. Sometimes they listen. My oldest son was an asthmatic growing up. And he's old enough that you didn't have home nebs. You had to go to emergency room. He would fight that neb forever. I was, 19 years old, trying to get this kid to do this. And we were in the emergency room one day, and a fireman walked by and was like, hey buddy, I have to wear my mask to breathe. And he was like, cool, put the mask on, and that was it. He never fought again, right? Like regardless of what anyone else told that kid. But that fireman telling him he had to wear his mask to breathe, he was like, oh, all right. So sometimes it's making that connection with them. Kids are awkward. Don't worry if you're awkward. They like awkward, right? Like I'm fairly awkward, and they're like, "Hi, you're funny, right?" Because I'm like, I don't know what I'm doing, sir. Like I called the little girl's sister one time. She thought, I am not your sister. I was like, are you sure? Because my sister's real mean. Her mom was all, and I was like, I gotta go. This kid's mean. And I just, but you just gotta work with it. Bribe them. Hey, I have stickers. I'll give you a popsicle. What would you never give them?
A hard piece of candy.
A hard piece of candy and a freaking glove blown up. They put those in their mouth, they bite them, and then there is a non-radiopaque piece of something in their airway that we can't find. And they cry and they cause air movement and it flaps, and then they're like blue because it's closed back over. Please don't give them a glove blown up. So there's different ways to administer medicine. Sometimes you have to swaddle them, sometimes you can, some kids are afraid of a syringe. If you put it in a cup, they'll take it. But when you have to get it in, like, what would be an example of a kid that you would be like, they have got to take this medicine? It's pretty simple.
Yeah, like temps of 104 and above.
Right. Freaking febrile seizure, right? What's going to stop the seizure? Getting their temperature down. What's going to get their temperature down? Tylenol. And they don't want to take it. You swaddle them, you fish hook them. It's literally putting a gloved hand in their mouth and putting the medicine in just a little bit. Back to some kids are jerks. They can still push that out with their tongue. You have to get a friend and double fish hook them. You will literally like this with a cork and they can't push it out. Some people will blow in their face. I don't usually blow in other people's kids' faces, but you can ask a parent to do it. It just kind of startles them and they take that breath. And then we always have the luxury of, you know what, it's fine, just gonna put it in your butt. And we'll give them a rectal suppository and we don't have to fight trying to get it in their mouth, right? So other challenges that you guys face are aggressive patients, mental health crises, special needs, difficult parents, patients with chronic illnesses, and the last thing I'll talk about is respect and diversity. Which one of these kids are you guys most concerned about?
Probably
A teenager? Which one did you say? Oh, the one that already scheduled. Agreed. That little sucker is gonna fight for his life, right? And he's small. So you feel bad. You don't want to put your hands on them. Especially kids with behavioral problems, the ones that medicines don't fix. They have outbursts. They're prone to violence. They bite. They kick. They scratch. They're really hard because they're little. And you're like, you're so little. Like, why are you being so bad? They can't really help it. You have to protect yourself, and you have to keep them safe too. Oftentimes it's getting control from behind them. Just kind of wrapping your arms around them and holding them and talking to them while you're doing it. Doesn't always work. Sometimes you have to medicate them. Teenagers tend to have a little bit more impulse control than little people. They usually know right from wrong more. Teenage girls, I feel like, tend to be worse than teenage boys. Teenage girls do not care. They're like, they'll pull back their hair and take out their hoops and they're like, let's go, right? Teenage boys, maybe it's because I can mom them. I can usually get them to back down a little bit. But they're both equal. They pose a huge threat to you guys, right? And they're hard. Like, I remember going across the hall, and we had an 8-year-old that was suicidal. And I was like, how is an 8-year-old suicidal? Like, they should be like worrying about their toys and like not showing pictures of stabbing their mom. Like, this is, you know, they're homicidal, they're suicidal. It took me a little bit to wrap my head around it. Like, I had somehow in my mind made myself believe that, like, everyone was kind of schizophrenic, right? You wake up in your 20s one day and you're like, oh, today's the day. But some kids have that from the very beginning. Nature and nurture were not on their side, and they just had the cards stacked against them, and you have to take them serious, because like, those are the little kids that try to smother their little siblings, and it's hard to wrap your head around. They're a kid, but it does happen. Mental health crises, we saw a huge escalation during COVID, right? You took these really social beings and you isolated them. And they didn't fare well through that isolation. So we saw a lot more suicide attempts, self-harm, anxiety, eating disorders. Those are all things that are just important to kind of keep in the back of your head, that these do happen to kids, right? Like, and they have a lot going on, their hormones are imbalanced, they're not always great at regulating their emotions. So getting them to the right place and just showing them some empathy and being kind to them, but also having you have to have like your border or don't let them manipulate you, because they're good at that. Patients with special needs can be difficult, right? Like you don't know what all of the special needs kids can have. Usually the parents do. Like have them help you. I can tell you the one thing I learned in PICU, like there are very few things I took away from the 10 months I was in the PICU. The biggest one is if your kid has a G-tube and they are having trouble breathing, open up that G-tube, vent that G-tube. That is essentially the same as you putting in an NG or an OG while you're bagging someone. It's gonna decompress their belly and it's gonna just give you that much more success. There's usually just this little thing that twists on there. Parents usually have it because their kid has a G-tube. Ask them for the connector, connect it, open it, put it in a chucks or whatever. That's gonna help you gain compliance with bagging. It's gonna help them be able to breathe better. That one is huge. Do you guys have any questions about kids with special needs or things that you maybe run across that you weren't sure about? Typical parents. They're supposed to be protective, right? That's their baby. So oftentimes they can't get out of their own way to let you help their kid. Peds calls are always they're high energy, right? Especially if that kid is kind of sick or kind of hurt. Everyone's on edge. Everyone's a little excitable. And so it's hard sometimes to deal with the parents. It's also important for you guys to remember where the parents are at in that room, right? Like the last thing that you need is an angry dad coming at you while you're trying to resuscitate their kid, which is oftentimes why you guys just pick up a kid and go, right? Because that environment is just not safe. It's fairly volatile. I try to listen to them. I try to incorporate them in the care, but I also establish my dominance, right? Because you brought your baby to me. Your baby is sick. I am trying to help your baby. I need you to back up. Patients with chronic illnesses, they can kind of pose their own issues, right? Like, take a hem-onc kid or a kid with cancer. They have had so much of their control and their autonomy taken away from them that it's important to give them that autonomy. Like, I know in an ambulance everything's on the left side, but man, if they want that blood pressure cuff on the right arm, put it on the right arm. Like, that is all they have left, is where that cuff goes, where that probe goes, how you give me the medicine, because they have to do this all the time. So I usually will negotiate that one, right? Like, all right, you tell me how you want to do this. You tell me where you want this at. It gives them that little bit of sense of control in a world where they've lost control over everything to do with their body. Special considerations. How do you guys safely transport a pediatric patient?
Should be in their seat.
You should be in a car seat, right? Like, it boggles my mind how many agencies still don't put kids in car seats or will have mom hold a kid on her lap, when we know statistically if an ambulance is involved in an accident, it's that patient, the person in the back, right, that's not strapped in, the attendant, who's usually the most hurt. That baby is going to be a projectile. There's no way she'll hold on tight enough, right? So if they have a car seat, I would always recommend using a car seat. What do you do if there isn't a parent for transport?
As in, like, the parent doesn't want to ride along, or there's just no parent there on scene?
Either.
If there's like a responsible party for that person, whether it's like a child at a school teacher, school nurse, can
It would
be a patient
most of the time be
representative.
like an implied or an emergency consent. When would you not take a kid? You show up at my house and you are concerned for my kid. And I'm like, do not take my kid. Are you gonna take my kid?
Call himself. I think parents are allowed to make that decision for their kids.
Right, and sometimes they are, right? But if you're concerned this kid's being abused or hurt, they're not in a safe situation, you don't want to leave them there. But if you just be like, you know what, Mom, I'm taking your kid, you essentially kidnapped her child. And if she wanted to push it, you could get in trouble. So get someone else involved. Get MSAP, get law enforcement, get someone else involved that says that baby's going, right? The state of New Mexico, the only people or entity that can take custody of a child is the police. It's not even CYFD, unless they are already in CYFD custody, and that happens by the police taking custody and then loaning that child to CYFD. Right? CYFD is just going to watch over them. The police have to take custody. So that's just something to think about, right? Because you just want to get that kid out of that situation, but you're putting yourself at risk. Same kid. You gonna call CYFD on your own?
Question. It needs to be reported.
Right.
Sure.
So how do you think it would sound better? You call CYFD and you make your report from your firsthand experience, from what you saw, from what you witnessed, or I call CYFD and say, EMS states, EMS said the house was dirty. EMS said there's drug paraphernalia. I don't know what type of drug paraphernalia. I wasn't there. Right? But you're gonna call. There's a good chance I'm gonna call too. But you're gonna call and you're gonna start that. And then I'm gonna call and I'm gonna be like, hey, we got this kid brought in, this, and this. I'm gonna make my own report. It adds to your report. And your report adds to my report. You can call CYFD and you can remain anonymous. You do not have to give them your name. And as long as you are reporting in good faith and without malice, you cannot get in trouble. So I always suggest that you guys call on your own, make your own report. You saw it, you were there, right? It's like, it is no different than you telling me what the vehicle looked like without a picture, right? You show me that picture, oh, I got it. But if you're just like, intrusion was bad, this happened, I'm like, okay. So it's the same principle, right? Like, you were there, you saw it, and you are an expert. And we're obligated reporters. We are mandatory reporters in this state. What are some healthy coping mechanisms that you guys have to help deal with the stress of your jobs? Right? I'm old, so I learned how to push it down and compartmentalize it and cry in my car on the way home, which doesn't work.
Exercise.
Exercise, right? Counseling, therapy, talking to someone, walking your dog, anything that makes you feel better is what you need to do, right? Like, you guys are lucky. You're in a time when they've started to change the stigma revolved around this. It's no longer, like, let's bring every rookie on scene to go see the guy who was decapitated by the semi, right? It's like, let's try to save everyone who doesn't need to see that from seeing that. It is important. You might not think it is, but you will wake up one day 20 years later and be like, what the hell? Why did I just think about that? Because you didn't deal with it then, right? Like, I always thought I was fine until I tried to go swimming and I can't put my head in the water. And I was like, what is going on? Like, I've swam my whole life. How can I not put my head underwater? Oh, because that's like a symptom of PTSD, right? So I'm pretty passionate about, like, you guys finding what works for you. Passionate to the point that, like, I am willing to give any of you guys my phone number or my email If you have a peds call that you're just having a hard time with, you're struggling over, even just I had this peds call and I want to run over treatment, please reach out to me. I am always here. There is nothing you can tell me that is going to shock me. So I think it's important you find someone you can talk to and talk to them. We will love and respect only what we understand. We understand only what we are taught or allowed to experience. Right? This is something that's important. A lot of words, but like the meaning of it is pretty simple. Do you guys have any questions for me?
No, there's like we're lucky enough, thank you for saying, but we're lucky enough to have those resources too, and same for you guys. You know, obviously you see a lot of stuff too. Going back to like Peds vital signs, I'll have to show you at some point. We have a pretty cool app. It's called Hand Heavy, and it gives us every pediatric from weight and age. It gives us their vital signs.
That's
from every
awesome.
point, and the dosing for whatever medication that needs to be administered, or medication errors, and same for interventions. It's really neat.
In that other presentation I had, PediStat has an EMS version. It's like $5. It's amazing. It's very similar to that. PALS now has an app for your phone, and it's like $2.99 a year, and it will go through every possible algorithm. The other presentation that I did, I kind of talked about like it's important to know normals, right? So normal vital signs, but also like how do you get a weight on a kid?
Age times 2 plus 8.
So 1 through 5, that's a great weight, right? Age times 2 plus 8. You can use a Broslow tape. But, so if I take off my shoe, I will fit on a Broslow tape. I have not been 39 kilograms in a very long time. So just kind of keep that in mind. Most 10-year-old boys are going to be bigger than me. Their anatomy might not be bigger, but like weight for dosing is going to be a bit bigger. But it is a good start. Making sure that your company has appropriate sized equipment for you. Putting an adult sat probe on a kid can give you an error ranging from like 30 to 50%, like 30% below, 50% above where that kid is actually at. That's a huge range, right? American Heart says using an improperly sized blood pressure cuff can give you a 30-point difference. That can shift your treatment, right? Like you may get really aggressive on someone that you don't maybe necessarily have to because you had the wrong size cuff on them. So having the right size equipment is important. Knowing how to use the equipment is also super important. They do it in the PDR, and then I'm going to start it at SRMC, so twice a week in the PEDS ER. And I'm going to do mine out of the ER, which you guys are all welcome to come to. I'll do it twice a month. They run through pediatric SIMS. The majority of the SIMS, the patient is in or ends up in asystole. That is the most common arrhythmia in children. They are 5 minutes long, and it just teaches you to work through a PEDS code. Often when I give this lecture, I will tell people the smoothest codes that you'll ever see are run by firefighters, right? Because you guys work together and train together, and you know each other, so you know what the other one's gonna do. Like, you watch a code in a hospital, and we're like a bunch of chickens with our heads cut off, right? Like, we're running around, nobody knows what they're getting, nobody knows what they're doing, someone's yelling. It's awful. The way to prevent that is by practice. And you just keep practicing, and you practice not till you get it right, but till you can't get it wrong. So my bosses have said that I'm good to go ahead and do that, and when I get it started, I'm happy to let you guys know, like when we're gonna be doing them, and if you wanna pop in, to do them, we'll just use like a low fidelity mannequin, with a rhythm generator, and you just work through these sims and codes, and they just help you get into that train of thought and that mindset. That helps take some of that anxiety out of that situation for you.
That'd be great.
Don't be afraid of kids, they're pretty cool. Like, I know they can be scary, but they're pretty cool, right? Like they just want to feel better, they don't like being sick. And oftentimes it's not their fault, right? Like very few kids will ask their parents to call an ambulance or bring them to an emergency room. It's usually the parent, right? So it's easy to get frustrated in the middle of the night when you're like, are you kidding? He threw up once. But it's not the kid's fault. Is there anything else I can tell you guys or share with you?
Oh, that was great.
Yeah.
Yeah, thank you for going over that.